bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, and the Holland Bloorview Children's Rehabilitation Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities.
Hello and welcome to today's episode of CAFC Presents. My name is Lisa Stromquist and I'm the National Coordinator for Quality and Patient Safety at the Canadian Association of Pediatric Health Centres. Today's webinar is titled Implementing the Collaborative Care Model, Strengthening Nursing and Collaborative Care. This presentation is brought to us by the National Nursing Network and will provide an overview of the collaborative care model and the process used for implementation, discussion of the importance of change management supports, approaches to supporting nursing practice and collaborative practice, and specific implementation examples for inpatient care units. So, as always, we take your questions at various times throughout the webinar, and I'll encourage you to type your questions into the question box as you think of them. So don't feel you need to wait until we ask for questions. Just get them in there and type them in as you think of them so that they're ready when we need to go for the panel. And feel free to come in and out of the webinar if necessary. We understand that sometimes you can get called away from your desk. This won't interrupt the session as all lines are muted. We do record the entire webinar, so you can always go back to the recording to catch up on anything that you might have missed. And this recording and other resources or documents, anything provided by our presenters, will be posted on the CAFC Knowledge Exchange Network. You can see up on your screen what we like to call the KEN. So it usually takes a couple of days to get that information up, and you will receive an automated message from the system that will provide the direct link to the page. And you can also use the search function of the KEN to find that information as well. And the KEN also provides an opportunity for comments if you're a registered user. So at the bottom of each page, you can put comments in and any relevant links or information so that we can continue the discussion following the presentation. If you'd like to post any other information that you think would be interest there. So right now it's my pleasure to hand over the virtual podium to Jocelyn Vine from the IWK Health Centre in Halifax. And she's going to tell us a little bit more about the Nursing Network and her colleagues joining us here today. Welcome, Jocelyn.
Thank you very much, and hello everybody. Welcome aboard. I'm just going to take a quick moment to let you know what the CAFC network involves in hopes that any of you who are not currently linked in with it might consider joining us. So we have been a loosely affiliated group for a number of years, and some of you may have joined a CAFC morning breakfast session with us. And during several years of discussion and consultation, we've been able to focus in on the three areas of that I've put in the areas of focus list: education, research, and practice and administration. So just to give you an idea, with the education focus, there has been quite a bit of previous work done on developing pediatric nursing standards and also an end goal of developing a pediatric nursing certification. And actually, Sick Kids is kindly hosting a consensus retreat on September 11th and 12th, which will further contribute momentum in that education area. So hopefully a number of you are either attending or someone from your organization will be attending. In the research area, we have a number of PhD and academic nurse researchers who are joining together with a focus on promotion and dissemination of pediatric nursing research. When we first started working together, we noticed that in looking at websites and things associated with our organizations, that pediatric nursing research really didn't have the level of profile that we thought it should have. And so that's one of the big areas of focus for this group. Under practice and administration, we're also looking at innovations in care from anywhere across the country, also changes or new modes of service delivery, and with, again, the focus on really disseminating those opportunities, sharing, and making connections so that we can all grow stronger in pediatric nursing practice. A couple of areas, for example, that highlighted in our consultation at the breakfast meeting at the last CAFC was really strengthening mental health skills across all areas of pediatric nursing, and also a focus on patient and family-led care, just as a couple of examples. And I do want to highlight that we will be hosting a breakfast session at the upcoming CAFC in Quebec City. So I hope if any of you are going to be at the meeting, you might consider joining us and adding your voice to what our opportunities could be together. So that's just a little bit of background on the nursing network. Also, if you want to join in and be added to the distribution list, in our slide deck, you'll see my email. So feel free to just send along your contact information to me in an email, and I'll make sure that you get added onto the distribution list. Okay, we're on our way with our CAFC Nursing Network implementing the collaborative care model and strengthening nursing practice. This was an initiative that we undertook at the IWK a little bit on our own for the first year, and then after that we were lucky enough to be able to work alongside of our provincial colleagues in the collaborative care model development and implementation. So it really turned into a very worthwhile and collaborative enterprise for our whole province. We, as the sole pediatric and maternal newborn organization for Nova Scotia, had obviously an emphasis on our population, but there were many common and shared themes and resources that we were able to maximize. I just want to tell you who is with us today. We have a really broad group of wisdom, wise people, nurses joining today. So there's myself, Jocelyn Vine. Also we have Christy Kempton, who's the manager for the Garin unit, which is the acute care unit for child and adolescent mental health, and she's also responsible for our emergency mental health and addiction service. So that's Christy Kempton. Darlene Inglis is the manager of our neonatal care team. Heather Simmons is the manager of interprofessional practice, and Heather acted as both our internal IWK project lead, and she also acted as our provincial project lead. So Heather has a lot of experience from within our organization and also through connecting with her colleagues across the province. Shauna Best is the manager of our Med-Surg inpatient unit. Rebecca Earle is an advanced practice clinical nurse specialist in complex and medically fragile children and youth. And Nadine Smith was a project lead for models of care within the Children's Health Program. So that gives you a sense of the expertise. So we hope you'll ask us all kinds of questions and share your ideas with us as we go. What we're assuming in terms of the audience is that we have a variety of nurses joining us, clinicians, educators, advanced practice nurses, managers, and directors. So we plan to bring you information that is coming from a varied perspective, and that way it'll be applicable to everybody in the audience. At least that's our hope. And we will also be bringing the nursing lens to the collaborative care model and our discussions, but I do want to preface the comments about that by saying that obviously the collaborative care model by its very nature is very interprofessional, and it's also very much tapped into the expertise of support teams. So that would include housekeeping, health records, all of this biomed, whatever the support teams were that were most involved in the particular care area. So I do really want to emphasize that as being absolutely fundamental to the work that we did. But we will be talking with a bit of a nursing-specific focus today because of the nursing network aspect of our conversation. I think those are some of the preambles. Up on the screen now, you'll see the collaborative care model. And there is a lot of content on this one page, and so we'll spend a little bit of extra time really talking about the model. So you'll see that the core elements are process, people, technology, and information. And of course, at the center is the patient and family. So those are probably key themes that you would be familiar with looking at, lenses that you'd be familiar with looking at within your care areas. But also in the four corners, you'll see some very critical elements that really are essential in order to move the collaborative care model and the culture shifts that are involved with that forward in a positive way. Strong and effective communications are obviously extremely important in everything that we do. I think committed and supportive leadership is absolutely essential, and we really had nursing leadership at all levels within the organization fully at the table for the collaborative care model, and that nursing leadership presence was essential ongoing and really was fundamental to our success. There is obviously a need for collaboration across the continuum of care, and also a strong focus on staff development and mentorship. So there's quite a few bullet points under each of the four quadrants: people, process, information, and technology. And I do just want to highlight that while we will be getting into a number of discussions around some of the staff changes that we made, I think it's really important to emphasize the need to look at all four pieces, all four quadrants of the collaborative care model in order to make the experience of developing a new approach meaningful, useful, and addressing opportunities to strengthen practice, to strengthen care, and to strengthen the support to clinicians, which is really what it's all about, and ultimately strengthening support to patients and families. Okay. Again, going back to the focus on committed and supportive leadership, one of the things that we did was engage organizational supports, and we've listed some of those there: quality and patient safety, and the leaders within that area. Patient and family leaders provided us input in their observations. Decision support obviously was very key because the data that we really spent a lot of time on came from our decision support team, and they really worked closely with us to make sure that they provided what we needed. We had the good fortune of having an industrial engineer involved in a number of different projects to do with the implementation. We had a project manager, as I explained. Heather Simmons took that provincial role, and we also have Nadine Smith with us today. Human resources were fundamental to the work that we did, both from developing, helping us develop the role description tools, etc., but also helping us with any labor relations aspects and working closely with the various bargaining units. Scheduling obviously is a key resource, and that can be embedded at a unit level, or you may have centralized mechanisms, but scheduling and looking at schedules is going to be a very important part of any review. And then obviously finance is absolutely critical, and looking at how your decision support data and your finance data marry up. Strong and effective communication. Can't say enough good about spending time on that. At a system level, one of the things that we really worked on was to look for key partners and trying to find others to work with alongside of us, recognizing the benefit of having either sister units or sister organizations in order to really compare notes and learn from each other. And we found that to be incredibly useful both internally, and then as the province launched the collaborative care model, that again gave us another opportunity to both share what we were learning and learn from others. And also we did end up developing a set of collaborative care approach for maternal newborn care across the province, which was disseminated as well. Department of Health was an important stakeholder for us, and depending on how closely your organization works with your ministry, you may spend time with them engaging on what you're doing and why. academic partners and researchers are obviously very important, and making sure that you have the engagement of educators as you go through the process, ideally from all domains, so that they understand what you're doing, why, can provide their expertise. We benefited greatly from the Dow School of Nursing. One of the professors there was actually provided a provincial evaluation of the model of care implementation in the province. So that's an example of the way partnerships can really work out. And then obviously right down to the nitty-gritty of how student assignments work, and there are so many opportunities. Unions were an important partner with us, and we wanted to engage our unions early and often, and we did do that. Within our own organization, we had a bit of a challenging situation in that nursing is represented by two different unions. So licensed practical nurses are under one union, and registered nurses are under another. So those are all considerations that are local context. And then all the other health professions are under a separate bargaining unit. But basically we developed communications and opportunities for collaboration with the unions, and then tried to apply that across all of the bargaining units. And we also had to engage the unions for our support workers. So for example, our unit A's and ward clerks, etc. And we also involve regulators in looking at the roles and scope of practice for nurses and all of the disciplines, in looking at opportunities to enhance scopes, maximize scopes, identify where the crossovers between different health professions are, and how to share aspects of scope. In terms of change readiness, we will spend a bit of time on various aspects of change readiness. As I mentioned, really understanding the information was absolutely fundamental. So as we went from two various units, we were only able to do a couple of units at a time because there is a fairly intense demand on the time of both the project leaders, the unit leadership themselves, and also our decision support, finance, etc. So we were able to look at a couple of units at a time and then gradually work our way through the various units, inpatient, and then we also applied the same framework and lens to our ambulatory care areas as well. Just wanted to mention before we go into the slide on information that one of the things that we did do, because we recognized we could only do so many units at a time and that there was some limitation in capacity, what we did do is set up an organizational committee that really brought together all of the key leaders, managers, our leadership from human resources, etc., and had a center-wide committee, and really gave people an opportunity to understand what was being done, what was the progress on particular units, what were some of the challenges that were coming up, what were some of the opportunities and recommendations, and share those broadly so that people had an opportunity to understand what we were doing, but also we had the opportunity to have their lens on what we were doing, and that by its very nature added a lot of wisdom and opportunity to that. Do either of you want to say anything more on that central approach?
Well, it was good in that all the managers and directors from all the areas that either had undergone models of care work or were in the process of it had an opportunity to learn from each other. So, you know, if someone brought up the idea, we're looking at this, and someone said, well, we tried that, or here's some things to think about, or even to run things by when recommendations were done, from a different perspective. So, for example, implementing a new role one person at a time, when we looked at that, it was thought it was better to introduce the role with two people at the time so that they had a cohort to work through the process together with. So it was excellent in regards to we had everyone at the table that could provide us insight when there was questions that arose.
Yes. Okay, that's great. So going into the change readiness information, these are some examples of things, and I'm sure you can think of many more. But what we found is as we got into a deep dive on the team and the unit data, particularly the patient populations that were served, the ages and stages of those patients, the complexities, the types of diagnoses, as we spent time really looking at the patient data and actually sort of subtracted ourselves from the busyness of the particular unit and really analyzed that patient data, it really helped us to see some patterns and helped us understand age groups a little bit better, the types of profiles of patients that were being served on that unit, and also, obviously, as I said, complexities, lengths of stay, different patterns that unless you really pull back and look the data very thoroughly, you might not see those patterns as obviously as you imagine. Timing of admissions, for example, was something that became very clear, particularly for our med-surg unit. When admissions were coming in, the percentage of those admissions that were emergency versus booked, probably many of you would say that it's similar for you, that the vast majority of the admissions other than booked surgery are emergency. There's very few booked admissions other than surgical. So that, and seeing the times of day that those patients would come in can help with patterns of staffing. It was also useful to go back and look at our patient feedback, particular themes that may be showing up through patient satisfaction, and also very important to look at staff satisfaction, the profile of the staff themselves, the lengths of experience, the levels of turnover, all of the elements that would really help you understand the profile of the team that is working with this particular patient group. Quality and patient safety data obviously was important. It was very important to understand the current state, but it was also a very important element in looking at how we would evaluate any changes that we made. And obviously all of this data is key to look to review ongoing. But I think from a quality and patient safety perspective, our staff were really felt much more encouraged with the changes that we made, knowing that we had picked particular indicators that we would be monitoring ongoing to either look for improvements or stability in some of those indicators. And that really helped to identify what those indicators would be early on. We also got into a fairly deep dive on looking at patient assignments, the types of patients that were grouped together, the types of staff, and this, again, was a bit laborious, but when we really went back and looked through in detail at the types of patient assignments that were being put together, again, patterns really showed themselves that were very useful and helped us to understand what we were doing and look and see patterns of opportunity. Staffing information obviously is very key, looking at existing core staffing patterns, scheduling patterns, experience levels, the various professions obviously that are involved in the care population and how they are assigned to that particular work area, and all of the turnover, recruitment, retention, overtime patterns, workload measurements, and utilization of staff time. So I know it's a lot of detail, but I can't emphasize enough how foundational that information was to us in starting to really pull back and take the time to really look at the unit and the types of data that would help us inform changes. We also spent some time identifying change readiness resources, and I know that you'll be able to name many of those if you have interprofessional practice framework, nursing frameworks, organizational values and principles that you go by, really pulling together what is the bibliography of principles and approaches to care that you want to make sure are thoroughly reviewed, highlighted, strengthened potentially, and embedded in the work that you are doing going forward. And as I mentioned, the health professional role descriptions and scopes of practice, we had done some work internally within our own organization because before we started this journey from a nursing perspective, we had an all-RN model within the organization. But as we started to work on this initiative at a provincial level, we had the benefit of having a provincial human resources approach in terms of developing standardized role descriptions across the entire province. And there was very active participation by professional practice leaders and frontline clinicians in all of the practice areas to develop role descriptions and scopes of practice. Regulators were also very, very much involved in verifying those scopes of practice. And I think that was really beneficial because what we did find when we started working across the province is that there are often traditions in terms of the scope of practice that become embedded within a particular organization or a particular area of practice. And when you really pull back and look at the actual scopes, people could be working at a more advanced level. And I think that's one of the themes that we would say is still requires a real focus of energy. And it will be something that we're going to put a real strategic focus on within our own organization. We still see a lot of opportunity to really maximize the scopes of the professions that we work with within the health center. So that may be a theme that's very relevant to you as well. We also saw our advanced practice roles as great resources. In advanced practice nursing, we have nurse practitioners and clinical nurse specialists. And we also looked at the potential for advanced practice roles within all of the disciplines. We also spent some time assessing the educational programs that we had within the organization and how they might act as resources in terms of staff development, because we knew that really putting a focus on developing the needs and the staff themselves through this journey would be so important. With regard to strengthening nursing practice supports, we really looked at a unit or team level approach. And one of the things that we spent a lot of time with was really engaging frontline nurses. So we had many fairly small nursing engagement sessions and all of the, as I said, all of the disciplines, but we are talking about nursing, to brainstorm the strengths, the gaps, the observations, the frustrations, the opportunities, and what were some of the leadership requirements and opportunities within at a team level. And that was also, it was very helpful in helping people understand what we were doing, helping them understand that we really were traveling this journey together, that this wasn't something with a foregone conclusion, that we had our mind made up on how we were going to approach the change. We really needed to understand the context of each individual team and the opportunities for each of the professions. Based on some of the information that we gathered and the data that I previously spoke about, we really tried to focus on what was the case for change. And we talked about that both at a local level, but also at an organizational level. And so that would include sharing the data, sharing the patterns that we were seeing in some of our data, sharing some of the realities to do with recruitment, retention, finance, and also sharing what we saw as some of the opportunities that were highlighted in that journey. We also really wanted to provide venues to ask all the hard questions, and we really encourage people to get those things on the table. What were the things that were worrying them, keeping them up at night, making them cross, or whatever it might be, so that we had a high tolerance for getting those issues on the table. We really tried to encourage the articulation of assumptions that people were working from, so that we could understand what each of us brought to the table in terms of assumptions, and then really talked about them and tried to work through, were they shared, were there core beliefs there that we had to preserve, etc. So we really spent quite a bit of time getting that information out. And the other thing that we did was accumulate those questions and answers and responses and shared those broadly across the organization with frontline staff, so that over time we had, quite a good record of some of the discussions that we had, which was also helpful for people to refer back to, and we put those up on our intranet. In terms of processes, we really looked from a care team level, we really looked at all of the tools that were available within a particular area, the equipment, right down to, were there enough thermometers or whatever the IV pumps were or whatever the things were that were an impediment to care. What were people having to chase around the unit to try and find? What was broken, what wasn't meeting the needs of patients and families, or what wasn't meeting the needs of the clinicians that were taking care of them. What were the technology opportunities, the information supports that people may or may not have had access to? What were the documentation processes like? And we certainly learned a lot about our documentation processes, and I think we still have a long way to go in terms of developing documentation processes that are smooth and don't take quite as much time. What we learned is that within our teams, often staff and clinicians will be spending 30 to 40% of their time documenting the various aspects of care. So ultimately, we're still working on that, and our province is moving forward with an electronic health record over the next number of years, and this continues to be a lens that we'll want to be bringing to the table, having documentation systems online that really work well for clinicians and help to save time and free them up to care. We also looked at care processes within teams and also planning processes such as discharge planning. We really encouraged a review of all of the environmental supports in terms of facilities, housekeeping, overall cleanliness, storage. Was there an opportunity to make sure that supplies were more proximal to providers? And that's all that sort of thing that would just make workflow work better. Job studies were really helpful, and this is where one of the many places where our industrial engineers were really helpful by tracking patterns of care delivery within units, tracking how far nurses were walking from A to B within the unit and how many zillion times on any given 12-hour shift. Also observing for interruptions and infection control patterns. There was really good information that was elucidated through job studies. The other thing that was helpful about job studies is it really helped us to sort of pull apart what aspects of work that nurses were doing or ward clerks were doing or unit aides were doing that may or may not need to be done by them. And really that helped us to identify whether there was an additional need for support staff to help relieve some of the nurses of some of the work that they were being pulled to that really wasn't necessarily done by nurses. We really spent a lot of time on active listening and responding to the needs of care providers and and certainly any tensions or anxieties that were starting to bubble up within care teams. As I said, we involved all of our support teams. Housekeeping was very, very important, and I think often housekeepers have observations within care teams that are incredibly valuable. So if you spend some time talking with housekeepers, particularly if you're lucky enough to have housekeepers that are assigned to particular care areas, they get to know the teams and they see patterns that we sometimes lose sight of. And I think that was particularly housekeeping was something that came out at a provincial level as well, that having really strong, well-supported housekeeping staff that were valued within the unit itself was invaluable support, and really looked at how we could strengthen that, those connections at the front line and within the leadership team to keep housekeepers happy and engaged and part of the team. Health records obviously was very important, and our observations of ward clerks and unit aides in the same way that I mentioned with housekeepers. They often see patterns, they see things that frustrate staff, and have many suggestions that are helpful. In terms of educators, roles and opportunities that came out from an education point of view, we basically used a very strong education and learning needs assessment approach for all of the work that we did, and that was at the front end, but also ongoing, and really developed materials to meet the needs of specific teams. And really also our educators were very helpful in supporting managers to make it possible for team members to participate and get access to the learning needs and the learning opportunities that were really important in terms of bringing the team members along. In terms of ongoing staff development and mentorship, we did have access to a series of educational modules that were provincial in nature, and they really focused on enhancing interprofessional collaboration and patient and family-centered practice. And so those modules were enhancing collaboration, interpersonal and communication skills, team functioning, roles and responsibilities, and we did put a focus on delegation and what was involved with delegation, what were the responsibilities, if there was delegation involved in some of the changes in the care model, decision-making and leadership, and of course, conflict resolution, always a vital skill. From a nursing manager's and director's point of view, and certainly from the perspective of myself as the VP, involvement and support ongoing of the process was really critical from a leadership point of view. So making sure that all of us were really involved and immersed in the journey itself and very much in touch with the units who were going through the process at the time, staying engaged and understanding what the climate was and any needs that the managers or directors might have. And really it is very key in terms of setting the tone of readiness and improvements, that opportunities that managers and team leaders are often aware of. So presence and participation at staff meetings is important. Supporting staff in the development and implementation of the supports that are really needed to change. I think leadership, openness to what the change may look like, and actually traveling the journey itself with team members is crucial. Ongoing support and leadership includes regular progress reporting and regular staff engagement. As I said, we met a lot, and if there wasn't a lot on people's minds, that was great, but they knew they had the touch point. So I'm just going to hand over to Rebecca Earle, who's a clinical nurse specialist, to speak to her points on advanced practice nurses.
Thanks, Jocelyn. I really like your note about traveling the journey, because I think that really what we did as advanced practice nurses in the health centers, we traveled that journey with the frontline staff. So we participated in the unit-based team meetings and the center-wide meetings that happened around models of care, and we really were there to provide that leadership for them to optimize their nursing practice. We were often called upon as well to attend some of the provincial education sessions around optimizing scopes of practice and translating that information back to the frontline staff. And we were there to just be a listening ear, to give the staff that opportunity to ask those hard questions, like you said, you know, and maybe in a confidential manner to help understand what they were struggling with, the anxieties around all of the changes. We worked closely with the unit-based educators as well to meet the learning needs for the staff. So I actually worked closely with the pediatric medical unit, so I helped to lead education days on those units, on that unit around scope of practice and collaborative care. We opened those education sessions up to our interprofessional team so that they could really understand what this new collaborative care would look like. And we sought out opportunities within the care team discussions, opportunities to strengthen practice, and then we went from there. I think we were instrumental in helping nurses really clarify what their scope of practice was, so not just from a registered nurse perspective, but also from an LPN perspective. And we coached them and mentored them as we worked together to figure out what our new care would look like on the unit. As I mentioned, we worked in partnership with the larger models of care teams to develop education, and something that came up in numerous conversations as we worked through the process was documentation, and how were we going to document with new care providers coming onto the unit. So I was actually quite involved and co-led a group that developed the IWK Interprofessional Plan of Care record. and helped with the education for that plan of care record and the rollout, and we also subsequently did an evaluation. I think we still have a bit of work to do on that end, and it's ongoing, but I find myself on the unit many times and coming back to conversation about documenting our plan of care for particularly our more complex patients. Another thing that came out of the work that we did as advanced practice nurses was the development of an ambulatory forum. So we recognized that there wasn't a lot of work being done in the ambulatory setting to allow nurses to have that voice in the ambulatory setting, to figure out what was the work that they were doing in ambulatory setting, how was it different from inpatient, what was nursing work, what was non-nursing work, what are some of the barriers that they had to do their work in ambulatory setting, and how can we support each other as nurses in ambulatory settings to work to full scope. We broke down a lot of silos, and I think we've had a lot of success there, but there's still lots of opportunity to maximize scope in both the inpatient and outpatient setting. So as APNs, we're continuing to provide ongoing change leadership in those areas.
That's great. In terms of the actual implementation strategies, we'll just go over a few key points here, and then we'll be able to give you some specific examples from the manager's perspective and the project leader's perspectives, which hopefully you'll find illustrative of some of the work that we did. The implementation strategies really focused on people, of course, because it's all about relationships, it's all about transparency and as much openness as you can possibly invest the time in. Addressing issues as they arise, documenting what the issues are, and documenting what the resolution was, so that there was a foundation of trust that when an issue was brought forward, it would be noted, respected, and then resolved to the best of our ability. Civility and respect in the workplace sessions was obviously a very key value, and always a challenge when people are under pressure, and that was certainly something that we paid attention to. There was an ongoing invitation for staff members to be involved in the process, and sometimes as units kicked off, staff members came in large numbers, and then gradually over time, as they developed confidence in the process that they could come at any time, but as they developed confidence in the processes, the numbers would go down a little bit sometimes, but we felt that as long as we kept everybody very well informed, that tended to keep people reassured that they had a voice. We had standing agenda items at staff meetings and care team meetings, and we certainly made it really clear within units that if there were ad hoc need for meetings or discussions of particular things that came up, that was always an option. The other thing, as I previously mentioned, was really putting a focus on communications through multiple forms, face-to-face, poster boards, fact sheets, an opportunity to submit questions through the intranet, and then, as I mentioned, the ongoing documentation of the questions and answers so that everybody could benefit from those things that had been asked by others. I'm now going to hand over to Christy Kempton. Christy is going to go over the journey from the Guerin Centre, which is our mental health inpatient area, and Christy Kempton is the manager in that area.
Just going to actually highlight some of the data that we uncovered when we went through our models of care process on the Guerin Centre, and Jocelyn had spoken to that earlier, but it gives you some of the information. It's not all of the data, obviously, but it gives it highlights some of the data that we use to actually inform our recommendations, and I'll talk about a few of those recommendations that we used specifically for nursing. So at the time that we did our actual models of care, about 66% of our nursing staff had 2 years of experience or less, and that remains pretty static for us. Right now it's about 56%, with around 70% with 3 years or less experience, and I think that's becoming more and more standard with many units these days. I don't think it's just for us. One thing that was interesting for us, because we thought it would have been weekends and the first of the week, was that our busiest days of the week were Tuesday, Wednesdays, and Thursdays. Most of our admissions occurred between noon and 11 at night. We thought it was later in the day, actually. Most discharges occurred between 11 and 8 in the evening. Most of our code whites or our aggressive incidents occurred between 3 in the afternoon and 11. That was not a surprise for us, certainly for nursing. Most of the nurse-to-patient assignments on our unit were 1 to 2 compared to 1 to 3 with benchmarking across the country. That was not a surprise to us. Our patient assignments still remain 1 to 2 or 1 to 2.5, and a lot of that is related to our experience of our nurses and the type of patient population that we continue to serve. Not all of it, but some of it is related to that. Not all inpatients with eating disorders were cared for on the Guerin Centre. At the time that we did our models of care, which was started in September of 2012, many of our medically unstable patients were cared for on our medical unit here, pediatric unit. We take a number of those more medically unstable patients now. That unit continues to take some of those patients, but we're working towards actually the Guerin Centre taking most of them in the near future. There will always be those few patients that will be required to be cared for on that particular unit, but the majority of them will be cared for, I would think, by fall on the Guerin Centre. So, patients' admissions have increased in the last 5 years, and we're at approximately 45% more admissions in the last year than when I started in 2009. And our length of stays actually have decreased from 23 days in 2009 to just under 9 days last year. So, what were some of the nursing-related recommendations? Well, to review our orientation and on our ongoing nursing needs, because obviously when you have a young staff and staff turning over, that's an issue. And it was not just an issue for nursing, but it's certainly where nursing is our largest number of staff, that was an issue. Continue with our point of care clinical mentors. That's a long term. That was a role that we had implemented on the Guerin Centre shortly before we actually started our models of care, because we saw such a need with such a young nursing workforce for support and for mentoring and to recruit and retain nurses, was that they needed a lot of support because we were so busy. We were the acute inpatient unit, and we are the only acute inpatient unit for the province and actually for the Maritimes. So we were serving a very special patient population. So who the point of care mentors were they were more senior nurses who were actually pulled from the nursing schedule. They do not take a patient assignment. They are free to do mentorship at the point of care. So they would take newer nurses and new to mental health nurses, students, and they would actually do mentorship with them. So if they expressed whatever that need was at that moment, they would take that particular nurse and they would go with them to do new assessments, to do new admissions, to work with them on developing a group and implementing a group. So they always had that resource there immediately when they needed that help, and that has certainly been a great success for us, and those point of care mentors remain on our unit. Look at reorganizing, provide more programming in groups in the evenings and weekends, reorganize staff schedules to meet increased demands on evenings and decreased demands on nights, bring nurse to patient ratio in line with benchmarking data of 1 nurse to 3 patients on day. So, under the people quadrant that Jocelyn has spoken about earlier, the point of care mentorship positions have been made permanent on the unit, so we continue to have those staff on the unit. And actually, we have senior staff rotate through those positions, so it's not one person permanently in them, which gives an opportunity for our senior nurses to have leadership opportunities and to develop their skills as well. And they really enjoy that opportunity. So like I said, we have about 60% of our nursing staff with 2 years or less experience and about 70 with 3 years or less. So, and that's really been a position that's been well received. And they actually do a lot of mentorship with our other staff as well. So another certainly something that's been done, and not just for the Guerin Centre, it's certainly been program-wide, is a commitment to nursing process development. And that's been evident certainly over the last several years. We've had 16 of our inpatient nurses do their CNA certification in psych mental health nursing in the last 3 years. We've had 3 nurses complete their provincial postgrad in psychiatric mental health nursing, and we have 4 others finishing this August. We have 7 complete the postgraduate course in suicide risk assessment, and we actually have an LPN who's doing distance non-certification in mental health nursing. And then we have a number of other education opportunities for nurses, but the program has really made a conscious effort to make sure that nursing has had the opportunity for a lot of professional growth and development. And certainly the Guerin Centre nurses have taken great advantage of that. So that's wonderful to see. Under process, there are now nursing-led groups on evenings and weekends. Some examples would be groups on mindfulness, groups on boundaries for patients. We now have nursing-led interdisciplinary reports and rounds that are much more efficient, and nurses attend rounds for their patients. When we were doing models of care, the actual nurse who had the patient, they didn't even attend report at that point in time. We have decreased the staffing ratios on nights, and we've actually increased the staffing ratios on evenings. So, because that's when a lot of our work was happening based on our models of care data. And we've actually hired a ward clerk on evenings, and our rec therapy staff do some evening work as well, so that's made a big difference. And we've also developed a role in eating disorder resource nurse role. They are a staff nurse that works on the unit, but they've done some certification and training in eating disorders. Anybody that receives the Canadian Nurse might have seen the article in March edition on that particular role. There was an article in that edition on those gals and all the work they've done on that. And that's made a huge difference in working with that patient population, and that's one of the reasons that we've been able to move forward with bringing the more complex patients down from PMU. So that's been very helpful. And the collaborative care guidelines that were put in place, actually they were put in place with us prior to starting models of care, because we went from an RN unregulated healthcare provider model to an RN LPN model prior to models of care. We continue to use that model, and it continues to work well. And under information quadrant, we actually have used a medical unit's patient acuity tool and morphed it into a mental health and addictions patient acuity too. And we're still refining it, but it's starting to work well for us, and we use that to help form our patient assignment, which is helping for our charge nurses to help with assignment. So that came from our models of care work. So that's just some of the nursing recommendations that came from our models of care, which was highly successful on our unit.
Okay, I'd now like to hand over the microphone to a couple of people who led the work on our pediatric inpatient unit, hematology, oncology, nephrology, and the med-surg neuroscience unit. So we have Nadine Smith and Heather Simmons, and we also have the manager for the medical surgical unit, Shauna Best, here with us. So they'll go through the next slide.
So these two units, after they had gone through the model of care work, had gone with an RN CTA staffing model, and a CTA is a care team assistant. They're the unregulated healthcare providers, not the licensed. And this was done, the decision was made after we looked at the work studies done by the engineering, the data from decision support, patient assignments, and the decision was, it was really understanding the roles of all three levels. So the manager and the staff involved in the decisions had to understand what do we want the scope of practice to be for the RNs, what can the LPNs do, and what can the CTAs do, and how will that look for our team. So it was decided that for these two units, there was inconsistent work for the LPNs. And once this decision was made, it was really important to orientate the frontline staff to what the role is going to be of the CTA, and how are the RN going to learn to assign duties to the CTAs, what is appropriate for them. And that's when we developed a scope of a working document for the staff to be able to look at to say what is the skills that the CTAs can do. And we developed what was key as well for the first unit to go through it was the med-surg unit, and one of the frontline nurses, myself, actually was pulled from the role of frontline nurse to be dedicated to the orientation of the CTAs. And having that dedicated person was crucial to implement the role, and we were able to develop an orientation program for them that included different members of the team, and it was a week-long a classroom, and then we had, I think it was 3 to 4 weeks of actual being assigned with a registered nurse to learn how the unit functioned. And that was important too for the nurses. We were, had to pick the right type of nurses to train them as well, because these nurses had to really understand the role of the CTA, and they came out of their role as a nurse for this. So the nurse didn't have an assignment that day. They worked with the CTA and performed the duties a CTA would perform. So that was really great at having the other nurses on the floor as well get used to what the role would look like. Ongoing communication throughout the whole process, and the manager was very visible throughout all of this, and she often attended the education sessions that the staff would go to, and that was great because then they really knew that she was very engaged with the decisions. We did evaluations of the role throughout the process, and ongoing now. The role has been in place for 5 years, and we're continuously looking at changing their scope of practice on the unit. We've increased already, what the CTAs can do. And certainly from a management point of view, they're always looking at the financial aspect of it. And one key thing that was important that the manager took into consideration when we were hiring was we went with 5 CTAs in the beginning and on MSNU, and I think 4 or 5 on maybe on the oncology unit. And these roles were posted as full-time or permanent in the beginning because we wanted to have the best candidates apply. And we were very, we spent a lot of time interviewing and made sure that because we were bringing in a new role to the health center, we wanted to have the best ones out of the program. So that was very key in the beginning as well.
Just a couple points to add to what Nadine was talking about is all those data review points that Christy referred to and Jocelyn referred to happened with each individual unit, and a group would kind of pull out pieces of the data, and we take that back to the team and validate it. This is what we're seeing. Is this what you're seeing? And what that allowed us an opportunity to do was to change some of the assumptions that people had made. So, for example, one of these units, when we had, I think, the first or second meeting of the team, it was said right out there, we will not have unregulated people on this team. And so when we dug a little bit deeper with that, why was that their impression? And then as they were part of that process of looking at the data, validating the data, looking at who's doing what, it actually, the team did end up differently than they initially thought it would. So it really is that journey, and the team being the journey, and the team being part of that process and coming to the recommendations. And sometimes that meant challenge them on some of the things they thought, and just really taking an objective view of things and bringing points forward. But it was the team that made the recommendations.
I think we certainly felt that on PMU as well, because I know going into it, our nurses felt that there was, all the patients needed a registered nurse. And then when we really looked at the data closely, we would see that there were, in fact, a third of the patients that could be cared for by a nurse other than or by a care provider other than an RN. And then it took some time to wrap their head around, well, what will the LPNs be doing that we have done all along? So it's challenging some of those traditions that we've always had and moving forward.
And as much as I'd like to take credit as being the manager who successfully initiated this models of care on MSNU, I'm not, but I was the lucky recipient of inheriting the model. And what I would want to add to what Nadine and Heather have already indicated is that the work really continues. There's a lot of energy that starts with initiating this kind of model review, and there's lots of people there's lots of resources around, and you can get lots of data, and it's great. But the amount of work that is required to continue to provide ongoing evaluation and really understand from the Nova Scotia Community College what they're doing with the scopes of practice, with the CTAs, and how do we make that now work on MSNU, what the growing realization is from the families and patients and other team members, what the CTA can bring to the role, and what the CTAs themselves frequently come and say, well, they're doing this, why can't we be doing that? We'd like to take this on. So it's from a manager perspective and from any leadership role, I would just say the work continues, and it's really valuable to, again, be seen as being very supportive of the art of the possibility. What could we possibly be continuing to grow in this role? And the other piece is that to be very comfortable with it being in a totally different direction than what you initially started with. We really did start with the CTAs being in a support role, and we were moving now into CTAs basically becoming the primary caregivers for some of our long-term rehab kids and gaining great job satisfaction out of that.
That's great. Any other comments before we move on to the next slide?
No, I think each team, it was said to them as well, this is not a project with a start and end date. This is a new way of how we do our work. And so it has become a gradual process of integrating it into our culture versus being a project.
Yes, I think that's absolutely true. The culture shift concept, and really using this lens with the quadrants and trying to think about what are the opportunities for innovation and change. And I think by going through the journey together as a whole, we've been able to open up a lot of different possibilities. And we haven't spoken to you today too much about some of the other roles that we've implemented besides a variation of our nursing role, but we certainly have been able to be very innovative with a lot of different people, with a lot of different talents in our interprofessional team. I'm just going to move the microphone a little closer here. In terms of the pediatric inpatient unit, so the pediatric medical unit, Nadine, did you want to speak a little bit about that one? And Heather? Okay.
The three of us probably.
Yeah, we can all chime in.
Yeah.
So when we looked at the data for the patient population in the pediatric medical unit, it actually became clear about 1/3 of the patients really did not need an RN to care for them. When we looked at scope of practice, what their needs were, complexities, all of that. So that was quite a surprise to many who actually thought going into this that it was going to be an RN CTA mix. And again, through the process, changed to recommending LPN. We did it cautiously on that unit because there were times when the patient population varied. So the lowest amount of patients on any given day that could be seen or taken care of by an LPN was 2 days a month. Most days it was more patients than that, but we did start out cautiously. It was the RN and LPN mix. There was consistent work for the LPN. Again, role clarity and orientation not only for the new role that was coming onto the unit, but all the other team members, because they had to understand what those individuals could and couldn't do, and how was that going to mesh with what they did. So that whole change in culture there. There was ongoing communication with the team in a number of different ways, and still regular ongoing evaluation and financial analysis. The one thing that our decision support department has been exceedingly helpful with is that initial pull of data, but also an ongoing updating of what we call the data queue for each of the units.
Yeah, and the only thing I would add is that, as Shauna said, the work is ongoing, so we continue to look at the scopes of practice, particularly for the LPNs. I mean, since we started out on this journey, LPNs are now moving into giving, IV medications, and now we're talking about, work with our TPN and blood products. So it's constantly evolving. It's not there's no end date.
No, there's no end date, and it's always that reassessment. Has the patient population changed? Therefore, do we need a different mix? Or now with changes in scope of practice, can that proportion of mix change?
And they just recently increased the number of LPNs in the last month or so, because of the changes in scope of practice.
That's great. Okay, I'm going to hand over the microphone now to Darlene Inglis, who's going to talk about the journey within the neonatal intensive care unit.
Hi. So there's a bit of repetition when we say, like Shauna, I inherited once the process was already in place in NICU. I hadn't been the manager at the time. So there were 12 LPNs that came on in NICU at that point in time, but also very much echo Shauna's comment about continuing to monitor and evaluate and change the model as needed, because it certainly is something that you need to be always aware of. What are the contexts in the unit that may be impacting this type of provider in your unit? And I'll talk a little bit about that after. But we too looked at our 40 beds. We have 40 funded beds in the NICU, 58 physical spaces, but for the 40 beds, we looked at our patient ratios and really determined that probably 80% actually were cared for by one nurse to 2 patients or one nurse to 3 patients, and the other 20% were one-on-one. So for the 1 to 2 and 1 to 3 patients, we also looked at the acuity of those patients and found that it did lend to having some LPN care providers in the unit, which at first, and Heather is here that also was there at first, could speak to that. There was some apprehension and concern that how far were we going to go, and were we going to be replacing many more RN positions with LPNs. But as we looked at the scope of practice and were very, very transparent about the population would be very much the predictable, stable, predictable patients, and that the care provider, the plan of care had to be well established, so new admissions were certainly cared for by RNs until they were stable and predictable and the plan of care was established. So I think once the RNs recognized that the population was very specific to the LPN care providers, they were a little bit more settled. Heather, would you say?
I would say certainly putting things out on the table is a great thing. My benefit with this area was that I used to work in it. Mm-hmm. So when we first had our first meeting to talk about what was models of care, what was the process, I was able to look at the faces around me, and a number of them knew me, and put it right out there. What are you hearing? What are the rumors? Mm-hmm. And so I was told what the rumors were, mm-hmm. and what they thought the process would be, and was then able to clarify some of those misperceptions. So they had heard, and I'm not sure who they heard it from, but that it was going to be 2/3 LPNs and only 1/3 RNs, which was not realistic with the acuity in that unit. So we were able to get some of those out and answered. And once they saw that they actually were the ones that were going to be making the recommendations, then they felt more part of that process, and it was their process.
Right. So when the other thing to keep mind of is how they are integrated into the team. So now that they've been on board for quite a few years, 4 years, I'm thinking, the relationships are well established. There's a great deal of respect within the team and the team members, which also then puts you at risk for when I talk a little bit about scope creep, because when people get comfortable with the care provider and they feel like they've established themselves within the unit, they can get a little bit more comfortable with what they're able to take on. So you need to address that as it comes up. The staffing model required considerable work to address. Obviously, we talked about the role clarity. The orientation needs also was a very important piece of this, in that we do our orientations with the RNs and the LPNs together. The two educators that are in the unit have a very clear idea on what is within the scope of practice of the LPN compared to the RN. So when they teach, they speak specifically to, this is the scope for the LPN, this is what the RN looks like. So I think that has helped with establishing some, the engagement of the staff feeling comfortable, but also with having them feel supported in the unit, and they get to know the people on orientation just like other RNs. Currently we have 12 RNs in orientation in the NICU right now, and 2 LPNs. And what I have heard a lot from some of the RNs is, wow, the LPNs are really coming with great deal of experience and are a good asset to the team. So I think we've come a long way. Again, we talked about scope of practice and the assignments and decision making. We didn't have the acuity tool in place when the LPNs were brought into the unit, but we have since adopted a Winnipeg acuity tool, which is called a wanted tool, and it really does help with decision making and assignments. So that's been a great addition. The other thing that when I talk about the recognition of the need for ongoing investment and support the competencies and scope of practice to continue to develop. The LPNs, as we meet with them, continue to talk about working to full scope, which is very good, and that you don't want to stifle their scope in any way, so it's important to make sure that they're being able to be supported through that. So we have the LPNs in the NICU giving IV medications, and there has been some certainly some significant education around that. The operational considerations that you need to be thinking about, though, is the type of scheduling and the FTEs that one would need. So we, first of all, started with 12 LPNs, and now we're utilizing 9, which seems to be just the perfect number. And it really is related to, we do a 2 days, 2 nights, 5 days off schedule. And if you have 1 or 2 on each group, they cross over, and then you get either 2 or 3 or 4 staff of LPNs. But then the staff also in that type of scheduling do owed shifts. So I couldn't quite figure out why sometimes the clinical leaders were having difficulty assigning the proper assignments to the LPNs, but the owed shifts sometimes will have more LPNs working as the groups cross over. So that took a little bit of sorting out, and now we've got them staggered onto the groups and just probably the right amount of numbers right now. The other thing that happened in the unit at the same time is well, over the last little while, we've brought on a women's and newborn health resource pool. So we have it's a float pool that floats between the 4 units in the women's program. And so when you bring other float type nurses into the team also, those assignments that they take on are a little different too. So when Shauna said that you always have to be thinking about the context of the unit, when you bring new initiatives onward, you have to consider what does the model still fit, and is there augmentations that you need to do with that model. So it has worked well, but we did have to make sure that we were paying particular attention to it. I think that might be the scope creep. I think is something that it's really important to address because if the LPNs may take on a little bit of, activities outside their scope, and it's not addressed, it doesn't give them the confidence, of course, and it's not safe for patient care, and it's not part of their licensure. But it is something that you want to address without it feeling punitive or restrictive to their practice, but that it really is about supporting the patient safety aspect, and it's supporting them in their licensure. So it's not to be punitive or restrictive at all, but they need to know that when it comes up that they can raise the issue, because sometimes nurses will say, oh, well, this nurse is so good, and the LPN can take that on, but it is really important that they know that you're going to support them in those decisions.
Wow, that's great. I think the bell rung. So that gives us 15 minutes for closing comments. We certainly hope that you have found all of the wisdom around the table helpful, and we look forward to your questions, and also wanted to highlight that everybody's email and contact and title is within the presentation itself, so certainly feel very free to reach out to any of us. We're always looking for partners and sister organizations to work with, so please feel very free to make those connects.
Well, thanks very much, Jocelyn and your entire team, Christy, Rebecca, Nadine, Heather, and Shauna. That's fabulous. I'm just waiting, give everybody a little bit of a reminder to type their questions into the question pane in your control panel. Should be probably on the right-hand side of your screen. A little bit of a reminder that the presentation is being recorded, and yes, you can view it at a later time, and it'll be up in a day or two. So I do have a question from Jane asking, can you speak to your experience in the ambulatory area?
So the one bigger challenge we had for ambulatory versus the inpatient units was actually accessing the data. It wasn't as clear-cut as the data that's followed with the inpatient units. So sometimes we had to use resources and blend information. So there may be databases that certain physicians were kept to certain ambulatory areas. So we have to import that data, the data that we could get from decision support. So we did more work in around staff perceptions in regards to what did they see the work of the day, the workload measurement. We did some imaging things in around if you were at a brand new facility and you could build this program from scratch, what would it look like? So we had to do more of that type of work with the ambulatory, but certainly the process in regards to once the data was obtained, about the data review and involving them in the recommendations and doing the job studies was another part of that. So our industrial engineers were very much involved with that, as well as suggestions from staff. What do you see that's working well here? What do you not? What are you hearing from families that we're not seeing in the family feedback? Because all those same aspects of data we reviewed, whether it was ambulatory or inpatient. But I must say we had to do a little more work in around job studies and input from staff around what their work was. And then it was a little more challenging sometimes to have them think about other scopes of practice within their settings because they had worked that way for a very long time. So then to get it up on the wall, this is what you said you did, and these are the different roles that actually could do those aspects. That was a little more challenging in ambulatory.
I think that's why we found such great benefit over the development of the ambulatory forum. So basically we were recognizing that we needed to spend time with the nurses in the ambulatory settings. And so myself and another APN started a group, and we met weekly with the nurses in the ambulatory setting, initially in medicine, and then subsequently a nurse practitioner led a group on the surgery side. But we would meet with them once a week, and we would be asking them, or not once a week, once a month, what is the work that needs to be done? What is nursing work? What is RN work? What supports do you think you need to help you do your work better and work to full scope?
And I think that was really important because what we did discover in some of the ambulatory areas is there were some individuals of the team that were working outside of their scope. So there was both that expansion of scope, so how do we optimize scope for the individuals, but also who was working outside of scope so that we could put those in alignment so the right people were doing the right work.
And subsequently, we've since, I know on the medicine side, we've brought in a ward clerk to provide support because nurses were doing a lot of non-nursing clerical tasks. So we brought that support in. We now have a clinical leader of development who's providing education to our nurses in the ambulatory setting. And the ambulatory forum has just taken off. We don't even lead the group anymore. The APNs have stepped back. The nurses are leading it themselves. So they meet monthly and they continue the discussions around the work that they're doing in the ambulatory setting. So it's fantastic.
And even patient flow studies, so in regards to how they enter the ambulatory area, privacy, where the conversations were occurring, were they audible to other patients and families, all those aspects were looked at when we did the ambulatory settings. So there was changes within our parameters that we could of physical space, so of taking one room and changing the purpose of it so that care providers could go in there and have discussions with other families hearing, things like that.
Great. We have a couple more questions, and Brenda's wondering if you can share your patient acuity tools that you've mentioned in the presentation.
Sure.
Sure. Is it something that we could post on the Knowledge Exchange Network, or I know that when you were during your presentation, you said some of them were still sort of in process, in draft, or you're still tweaking them.
I think what I'm seeing heads nod here with definitely a willingness to share the tools we have, and we'd especially appreciate anybody who has an interest in them to connect with us so that we can further hone and gain each other's wisdom. That would be super. So yes, we could definitely share those.
Great. Thanks very much. And Jane is also wondering if you were using a nursing workload measurement tool, and if you could please describe the tool or tell, or say what type of tool it was.
Well, we use the Emerald tool here. What I can say, with every single area that went through the process, we end up changing the tool. Because we did not go through a single area, whether it be inpatient or ambulatory, where we didn't discover that there were some aspects of care that just were not being captured or not being captured to the detail we wanted. So I would say every single area, and not only nursing, but other allied health as well, the tools have been changed.
And I would say we need to echo the continued monitoring of that even once we changed it, I think we've now gone through at least 2 more iterations of tools for RN, CTAs, pharmacy tech. Like, there's been so many different tools developed, but now we're into revising them. It really does feel like it's just a part of an annual review that you just have to look at these tools because it changes so much. Yeah. Particularly when you get a feeling when you're getting the reports back as a manager, when you're getting the reports back and the utilization doesn't feel right, then when you start to do a bit more investigation, you start to find out that actually more has shifted from one provider to another.
Great. I don't have any other questions at this time. Again, just a reminder, if you have any questions or comments, a number of people saying thank you very much, and this was very informative, very interesting, and I think they would like to maybe hear some more later on as your process continues. And again, we can invite everybody to join the Nursing Network at the CAFC conference. So that'll be Tuesday morning, I think October 20th, I believe is when your session is, and there'll be more information on the CAFC website.
That's great. If any of the listeners have suggestions or topics that they're interested in hearing more about, we definitely appreciate hearing. So feel free to pop us an email, any one of us, and we can certainly look at what we can do locally or reach out to our other nursing network members. And we look forward to getting to know everybody more as we tighten up and really make the network very vital and available to meet each other's needs. Thank you for the time.
Yep, thank you very much. We'll just Just want to remind everybody that we do our webinars every Wednesday at 11 a.m. Eastern Time. And it's always great. We love it when you can watch live, as the questions and the comments really enrich our discussions. But if you can't watch it live, just remember that the recordings of these sessions are made available on our Knowledge Exchange network. And a bit of a reminder, if you haven't received the notifications, we do have a great lineup of webinars for the next couple of weeks. Next week, Managing Privacy Risks when Building a Learning Health System. We'll be joined by Dr. Khalid El Amam from CHIO and Dr. Ann Kavukian from the Privacy and Big Data Institute at Ryerson University. So they'll be discussing the challenges of managing privacy risks. And then on July 29th, we have a presentation from Holland Bloorview on the implementation of their new Connect to Care online portal. August 5th, we'll hear some of the unique perspectives regarding delivery of air medical services in the Canadian Arctic, including the Yukon, the Northwest Territories, and Nunavut. So some pretty interesting presentations coming up, and we look forward to seeing you next time. Thanks very much.